Should I start?
Sir, I'll just introduce the speakers.
Okay.
Yes. Yeah, thank you. Good afternoon, everyone. On behalf of the Asian Society for Emergency Medicine and ITech India, I welcome all the participants for today's webinar on COVID-19. We have 4 speakers with us today. Dr. Tamorish Kole, the President, Asian Society for Emergency Medicine, will speak to us on the Emergency Department, Preparedness and COVID-19. Dr. A.S. Valan and Dr. Daniel from CDC will speak to us on the infection prevention control for COVID-19, preventing healthcare associated illness. And Dr. Rajeev Sharma from CDC will speak to us on international and national framework for COVID-19 response. The session will be open for question answers at the end, and participants can also type in the chat box. I now request Dr. Kole to kindly take over the webinar.
Okay, thank you. Okay, so good afternoon, everyone from New Delhi, India. And I know that many of our colleagues are in front line working now for COVID-19 across the world and across Asia. So I requested the organizers to record this webinar and put it into web so that it can be viewed later. So I will be speaking on emergency department preparedness for COVID-19 and it should be covered in half an hour, and then the other speakers will take over and we'll take the questions at the end. So as introduced, I bring greetings from 4 organizations. The first is my hospital, which is currently located in Delhi NCR. One of our hospital is a dedicated COVID hospital, and 2 are also receiving COVID patients, as like many other hospitals. I also represent Society for Emergency Medicine. I was the past president of the society and also the current president of the Asian Society for Emergency Medicine. And I work with International Federation of Emergency Medicine as the chair of Disaster Medicine Special Interest Group. So I'll be brief. I will be speaking on the overall change and the change of the direction which we need to adopt for emergency department. And as we all know, that emergency department is the front line of all the front lines, and that's what people have started describing emergency department. And it is good to see on one hand that the whole world has been, realizing one more time of the value of emergency medicine as a whole. World is also realizing the plan for pandemics, the role of public health and epidemiologists, as well as the folks in critical care medicine. So this is kind of a resetting of the whole healthcare system, and I hope that the healthcare system will really reshape learning from this experience. So I'll be presenting you on the 5 different, experience or the guidelines or the articles which have come up recently. And each one of these, in my view, coming from different setups and perspective. And I guess that if we summarize all these experience, there are, lessons learned from each one of this. And that is how we will be able to make change in our own system. Because no system in the world, as we know currently, is appropriate, is effective to deal with COVID-19. So the first position statement, which I'm going to discuss in detail, came from the Royal College of Emergency Medicine in UK on 6th of May 2020, and the title was very appropriately titled Resetting of Emergency Department Care. And that's what we are aiming. Some of us are doing it, some of us are planning to do it, and some of us are facing challenges to do it. So the first and foremost, we need to understand that the COVID-19 has brought a significant disruption to the way the medical care is delivered across all areas of practice. And as we move from a pandemic to endemic state, the delivery of the care, as I was just speaking a few minutes back, must be managed safely. And that include emergency department, the first front line of care in any hospital or healthcare system. And this recommendation is around 5 fundamental aims, which I believe is the fundamental aim of emergency departments anywhere across the world, in any socioeconomic structure or any continent. See, first and foremost, we need to understand that the emergency department as well as hospital must not become reservoirs of nosocomial infections for patients. This was a concern for a long time, but now we are realizing that we need to deal this very, very strictly. The second and the most peculiar for emergency department, as we know, across the world, especially in the Asian context, our emergency departments are overcrowded because of lack of adequate emergency care, the lack of proper system. Uh, but COVID-19 has shown us that there should not be any more overcrowding, and we should work towards that. How do we work infrastructure wise and system policy wise, that I'll discuss in detail when I proceed and for the presentation. As well as the hospital as a whole cannot be crowded again. And as we know, again, many parts of the world, the hospital is overcrowded, and that cannot be allowed again. The fourth point, which is again very, very important, that we must design emergency care to look after the vulnerable patients safely. This is again a long time concern. There are efforts towards building the emergency department safe for pediatric age group patients as well as geriatric age group patients. But once again, COVID-19 has shown us that we need to take this with a different mode and different interest going forward. And finally, last but not the least, that the emergency department must be safe workplace for the staff. Because if we continue to work in an unsafe way, at least during COVID-19 and post that, whenever future epidemic or pandemic threats come, we must not add ourselves to the group of people who are suffering from the disease itself. This is an inherent risk. Many parts of the world, including many Asian countries, in India as well, many healthcare staff are falling sick. But our aim has to be, to protect them, to look after them whenever they fall sick, and to monitor them before they fall sick. So first and foremost, as I told you, infection control practices, that should start from the part of EMS or emergency medical service, the patients who are brought in terms of critical illness, that need to be looked into very, very seriously. And it should be assumed that they are having the infection until more information is gathered, and they should be segregated and treated at the same time. There should not be delay in treating these patients. There are instances when patients are brought in emergency department in cardiac arrest, and staff was taking time to resuscitate them. This happened in many hospitals. We should prepare ourselves better so that this does not happen in future. At the same time, the staff will also need to have appropriate levels of personal protective equipment, and that guideline should be revised time to time and should be strictly followed. The triage process again should be routinely considered the infection control and the hospitals, leading to reduced hospital-acquired infections for patient and staff. And finally, the tests with rapid turnaround of results should be readily available to ensure patients are nursed in appropriate areas of the hospital if admitted. I know many hospitals and many healthcare systems, they use point of care test very effectively, but there are more than that. There are a number of hospitals or healthcare systems that does not have access to point of care testing or rapid turnaround of test. That will pose an additional burden to going forward, and that needs to be addressed. Continuing on the lines of infection control, the clinical staff will need the levels of PPE appropriate to the risk, and I will share in another example how that can be done effectively in giving people appropriate PPE, and as well as reducing the numbers of PPE usage according to the level of threat or exposure in that area. There has to be rigid visitor policies, social distancing should be assumed, especially in the waiting area. An emergency department should establish the maximum occupancy for each area that allows adequate social distancing. And hospital bed occupancy must be maintained at a level that promotes good infection control. Come back to the same point that we cannot allow overcrowding anymore in our healthcare system in view of COVID-19. There are two more points in terms of reducing crowding and improving safety. Now, there is one element of critical illness and injury which we treat day in, day out, and there the ambulance service or the the pre-hospital notification must have and connection with the hospital information system, because there has to be some amount of time which can be reserved for better planning, where when the staff has got a pre-hospital notification. And this is not a very costly technology. It can be simple SMS based technology as well, but this information must be available for staff to prepare themselves. In terms of non-time critical presentation, the clinicians from all spheres of practice now need to be more involved in the urgent and emergency care pathway, and so that the patient can receive early specialist opinion, and then the patient, if there is a need, patient can be moved on to the most appropriate facility for definitive and rapid care. This is a problem in many countries, and therefore the help and the coordination from other colleagues will be absolutely necessary to address this. Emergency department alone cannot solve this problem. The hospital or healthcare system has to come and work together with ED to address this. And there are this enormous number of patients which we see who is under active specialty care, but who presents to emergency department either for a complication or from a post-operative need, so on and so forth. And hereafter, it is strongly advised that these patients cannot show up in emergency department just for advice from specialty teams. And this should be handled in a different area to reduce the overcrowding and the risk of infection in an emergency department where large number of patients of unknown status are coming without proper notification, which is not possible many a times. There is also a need for physical redesigning of the department, and what it aims at to segregate the areas appropriately, and also to reduce risk of aerosolization in certain areas. So therefore, there is a lot of need to redesign the department. That doesn't mean that you need to construct a new department or to make or break many parts of the department. If you look around your hospitals, mostly emergency department are located in the ground floor. There can be areas which can be co-opted for emergency care, and basically the aim is to split the workflow and split it and spread it horizontally, so that there is lesser risk of overcrowding and more efficiency in terms of flow and dealing with patients who need isolation, infection control, so on and so forth. And there is also, as I told before, there is a need to have access to point of care testing, as well as good access for COVID-19 testing and a rapid turnaround time. Because in emergency department, there are patients who will be turning up with COVID positive report. There will be patients who are suspected COVID, and there are patients who will be coming for other emergencies as well. So you need to, deal with all these kind of patients, and very important and effective component of that is to have these testing results as soon as possible, so that the turnaround time is lesser and the patient related decisions are taken as early as possible. To deal with an issue of overcrowding, as I told before, that it needs to be taken seriously by the leadership. It is just not emergency department problem. As we know, it is a hospital related problem, it is a healthcare system related problem, and it is a national and so how does this overcrowding during COVID and post-COVID? Well, we need to have some kind of flow and decision making tools. There are tools which are available. I just wanted to have one which can give you a very early indication on what's going on in the department. And these kind of tools and decision-making ability needs to be taken into consideration in future, and as we are dealing with COVID-19 as well, because these tools will help you to plan early and to avoid any kind of serious issues which may arise in the department or the hospital or the healthcare system. The second example is from San Francisco in California, and this project is related to create an ED accelerated care unit. So this was published on 27th May, and this was done, as I told you, in the Department of Emergency Medicine at San Francisco. They purchased 2 negative pressure treatment shelters. Of course, the cost is high compared to our Asian system, but we can create these things in our countries as well. And they operationalized 2 shelters over 6-day period from the delivery time. The layout of shelters were initially developed. They developed a Unit 1 and Unit 2. The Unit 1 was carrying out full triage, where the patient care was continuing to have used to occur in chairs as well. They used to do rapid treatment and release without nursing involvement after triage process. And there was a portable X-ray. The care Unit 2, which was include treatment cots and trolleys where nurse is assigned to each patient. They were treating high acuity patients and full ED treatments are available. Basically what they've done is the extension of the emergency department into care areas so that the flow and the process is split and horizontally spread. And that's what I was talking earlier. So this is an flow chart of ACU1 and ACU2, and as you can see, the ACU1 was triage, treat, and release, and ACU2 was doing extensive care. They were treated with a negative pressure, and they were discharging home within 6 hours, IV fluid, limited IV medications, and versus ED in the private room versus inpatient bed direct admission. So what they achieved was they were able to treat the surge. They were able to split the services horizontally, and they were also able to reduce the chances of infections to the healthcare workers, as well as from one patient to another patient. This is just an example of their quick triage, which they set up in the beginning of this ACU1. This is inside ACU2, and they were treating patients effectively. They also used free cloud-based online communication tool in terms of using checklist, communicating between the teams, because as you know, there are frequent change of teams because the teams cannot be exposed for hours to the work of COVID-19. So there is suddenly increased handovers, new staff coming in, and all that issues are cropping in, which may hamper the continuity of care. So to prevent that, they used a cloud-based tool, which according to them was very, very helpful. And I think a lot of cloud-based free tools are available, and we can use them to communicate between the teams for better care. This is in total about what they did. Just see that the main emergency department was kept reserved, and this ACU1 and 2 was placed in front of the main ED. And main ED was actually acting like an extension of the hospital, so that it was used effectively for the work which could not be done in the ACU1 and 2. The next one, which I'm going to discuss, is about how to manage COVID-19 in terms of emergency department care in the low resource setting. And here I would like to quote this paper which came out from African Federation of Emergency Medicine on emergency care on low resource of COVID-19 adults in low resource settings. So what they did is almost similar what the colleagues in US did, but they could not, they did not use the the negative pressure taints and all that other things, because it's a low resource setting. So they readjusted the flow process in terms of patient handling, and readjusted the space which were already available to them. So if you can see, they were screening the individual outside of the emergency unit, and if those screened, they're using this chart which was there, which is there on the slide as well. And if they were positive, they were giving mask to them and demonstrating how to apply it. And then they were sending them to COVID area inside the emergency unit, and they were using the triage criteria, the triage which was there, which is there. If they were screened negative, they were using a screening stamp and allowing entry to the emergency unit. And patients were going to a non-COVID or a normal emergency unit, almost similar concept of the US colleague, what they did. And if the patient was non-patient, and they were following the normal hospital protocol, and they were sent to the other areas of the hospital. So this is in a nutshell what they did, what they suggested, and this was used in many countries. And they were using a lot of innovation, using the local things which are available to them. And this is just one example where the selected patients of COVID-19 who had to use the metered dose inhaler, they were using the plastic bottles and normal inhalers. And they were not only using them in the hospital, but also using them in the community as well. So there is also a great need of innovation using local resources as per the country and the healthcare systems, and what is available and what is prevalent. And this also needs to be looked region wise, because there is no one formula which can fit the whole world currently. There is another one, the fourth one, which I'm going to discuss. This is from Canada. This is about redesigning a rural emergency department. This is again published on April 21 to prepare the department for COVID-19. Similar approach, just like the African one or the US one. Here, what they did is they grouped the patients into two, as we all see the patients. Some of the patients come by ambulance, and some of the patients are walking in. So they were assessing them on the porch, and using their local guidelines, and they were dividing patients into respiratory symptoms and non-respiratory symptoms. And then they were treating them and allocating them into different areas. For example, if the patients were critical, they were assigning them in the trauma bed or the emergency department bed, where they have access to bathrooms, there were observation rooms. But if the patients were non-critical, they were offloading patients and sent to the main screening door, where the other screening of the hospital's other patients were happening. And if they were non-critical, but they could not work, then they were using other areas as well. And similarly, the walk-in patients were also treated, also segregated in separate manner. The bottom line is the same, that you need to use your areas in the hospital in vicinity of your emergency department to improve and to segregate your process flow. If you do not have the capability of a system or capability of adding a system outside your hospital in forms of tents or rebuild something like that. And that seems to be a very practical advice for many of us who are trying to redesign and reshape the emergency department accordingly. And the segregation of patients in this way, in this Canadian study, with physical barriers, allowed a reduction in usage of PPEs because the type of PPE in the designated areas were based on the guidance from the regional health authority. And this is true for emergency department in any part of the world. If we divide the areas and according to the risk, not everyone need to wear the full precautions and the complete PPE. There are areas which is just screening the patients and can be dealing with a lesser set of PPEs. But that needs to comply with the regional guidelines, which I believe in most of the part in the world now we have access to. regional guidelines. Now, just before I end, I would like to leave with some of the recommendations from the colleagues who are riding in the ambulance. So these are EMS recommendations which came up recently. So first and foremost, if you are dealing with cardiac arrest, ensure good mask seal with bag valve mask, but avoid it as much as possible. Consider early advanced airways and consider the validated termination of resuscitation rule to avoid futile transfer. We have seen in New York that many patients are who had arrested, they were terminated resuscitation in the field before going to the hospital, because at that time, going to the hospital was resulting in a lot of futile transfers. So that needs to be borne in mind. Also, there is a need to avoid the intranasal medications. So alternative routes for administrations for medications has to be chosen. The STEMI patients need to be screened for COVID-19 and the receiving hospital should be notified. Paramedics should wear again the same appropriate level of PPE for all calls, and transport only if the higher care is needed. And finally, as we were discussing previously, pre-notify all receiving hospitals because they need to prepare themselves, they need to receive the patient at an appropriate area. And if they need to perform an aerosol genetic procedure, they should be ready. Also, some of the things has to be considered and should be avoided as much as possible, which includes bag valve ventilation because it generates, these are all aerosol generating procedures, nebulized medications, and the non-invasive ventilation as much as possible. So this is few advice for the colleagues who are working for EMS and working outside the hospital as well. So in a nutshell, as what we learned so far, we learned few things. The first and foremost is we need to reset our emergency care and reset emergency department as per our resource settings and local guidelines, but we need to reset. We cannot work like the way we have worked so far. Secondly, what is important to understand is that the overcrowding or overcrowding related issues has to be dealt very, very strictly. And we need to also be aware of the fact that the overcrowding is not only the emergency department problem, it is a hospital problem, healthcare system problem, a national and a global problem. So here, there is a great need of consultation and further working on this direction, which is required. Thirdly, the appropriate levels of PPE, the PPE supply and PPE guidelines should be maintained at all times to protect the front line of the front lines. And finally, the non-emergency department work, which have been so far happening, because emergency department is a fast system. It is an effective system. It works 24/7. It is a 365-day system which does not fail. So generally, patients and other clinicians and other specialists have an affinity to come and seek help of this. Now, this has to be used very, very carefully, because if we continue to use the patients and the other specialists continue to use emergency department like before, it will be overcrowded. It will be a source of infection, not only for the patients, but also for the staff. And if this continues, we may lose a significant amount of emergency care in our system. So this has to be taken care and avoided safely. Finally, I will say that we are in a state of learning. We will continue to learn, and whatever comes in any part of the world which is effective, cost effective, and effective to reduce the infection in view of COVID-19 or as a whole in future state of pandemics or epidemics should be replicated across the world. Thank you.
Thank you, sir. I now request Dr. Daniel, Medical Officer, International Infection Control Program, US CDC, and Dr. A.S. Valan, Public Health Specialist, Division of Global Health Protection, CDC India Office, to speak on infection prevention control for COVID-19, preventing healthcare associated transmission. Over to you, sir.
Thank you very much for the opportunity to present to you today. I'm here with my colleague, Dr. Valan. We're from the Centers for Disease Control and Prevention, and we're based here in India. I work for the International Infection Control Program, which has worked extensively for around the world in infection prevention control and AMR surveillance. And it's a pleasure for me to speak with so many of you who are on the front lines and are doing so much good work. My topic today is around hospital preparedness and infection control for COVID. One of the primary things that has been articulated is that in healthcare systems, the primary purpose is to maintain that healthcare system, especially during a pandemic, not only for COVID patients, but also for non-COVID patients. I think Dr. Kole has done a nice job of giving us examples where emergency rooms have been trying to separate out those that have COVID and those that do not have COVID in order to allow care, especially for those that are vulnerable, the elderly, HIV patients, those with cancer. One of the things that I'll be more brief about in this presentation, because I think it was covered, is the priorities to identify cases and then isolate them and then make sure that public health officials are informed as well as your own staff. This is a focus on triage and isolation. In setting up your triage and isolations, there are several aspects that have been already discussed. Maintaining social distance, which in India is often very difficult. Maintaining a triage that can provide masks, sanitizer, tissues to patients. Setting up a situation where there's distancing, so using your emergency rooms and reconfiguring them so that there's clear separation for individuals who may not be aware that social distancing decreases transmission. And again, I think that Dr. Kole has done a really nice job of separating this out. And this is just a different way of looking at this diagram of making sure that you have clear signage on where people should go. Those that with symptoms should go to one area. Those without symptoms should go to a different area. This is an example from Tamil Nadu in a triage area in a simple clinic where they're social distancing. And they've put in markers on the ground to make sure that people maintain that social distance. Here are some examples from around India where seats between patients are blocked so that they are not used. And then outside as well. So in preparing for triage, it's important that there be clear signage at the facility entrance to direct patients to where they need to go, making sure there's face masks. There's been a lot of discussion around spread from patients who are pre-symptomatic or asymptomatic. And in areas that have what is suspected to be widespread transmission, those areas, it's important to have face coverings, and we go into that a little bit later. Also, for your hospital staff, some kind of physical barrier at registration will allow you to decrease the use of PPE and also maintain safety for your staff. And then, of course, isolation rooms when you do have patients that are suspected of having COVID that are well ventilated and separate that. So this is just examples of simple signage. Local language, of course, is the best if you develop those on your own or have them from the ministry. This is examples where social distancing was not being done and would be a high risk for patients coming into this area, and an example of where plastic barriers can protect staff. Of course, this is an imperfect example as there's a gap there, as you see between the window, something that they would need to fix. Healthcare workers, one of the main issues is adhering to standard precautions. And from studies that have been done over the last many years, we know that healthcare workers are often substandard in their adherence to washing their hands and doing standard precautions. And added to this is the need to have social distancing. And so setting up your emergency room so that there is that social distance, using things like non-contact thermometers. And then of course, we've talked about appropriate PPE. Patients presenting should be screened and ask questions based on what the issues are in your area. If there's little to no transmission, then asking about travel history or contact is more appropriate. If there's widespread or felt to be widespread transmission, then it's less relevant. And of course, adhering to all protocols from your local public health authorities. This is just an example of how triage can be done in a schematic where patients are identified as having symptoms and then asked immediately to wear a face mask and perform hand hygiene. And then of course, and depending on if there are areas where there's felt to be low or advanced transmission, asking about symptoms. Isolations of patients, ideally is in a well-ventilated room with single rooms. Often that's not possible. And so putting them in well-ventilated areas so they maintain that 1 meter at least of separation. Also, cohorting healthcare workers, taking care of those patients is appropriate. And I'll give an example of how important that is. Making sure that all healthcare workers in that area adhere to the standard contact and droplet precautions. So in setting up your emergency room or triage area, this is a guide that's available from NCDC, available on the website, Ministry of Health and Family Welfare. This is a checklist. What's not pictured here is the individual checklist. So if you're interested in understanding if your facility meets COVID preparedness, I refer you to this guide so that you can use on a regular basis in order to assess if your triage areas are set up appropriately, if your isolation facilities have, and then other aspects of your facility that maybe you're involved in as well. This is an example of an isolation facility where there's clear separation, there's appropriate ventilation equipment, and then the staff are in appropriate PPE. Early on in the pandemic, one of the things that we, when we were engaging with different hospitals, was there wasn't appropriate planning for beds for COVID patients. Because initially, I'm sure that now that you've had experience, the cases just keep coming. And initially, you can put them in isolation rooms and have a small number of staff deal with them. But as the cases have risen, whole units, wards, and even hospitals have been converted. And a real need at this point, as cases are going up, is to do what we call reverse isolation and have designated units where patients who are vulnerable, who do not have coronavirus, are taken care of. We know that emergency rooms work at or above capacity, some of the busiest places in the hospital, and that in addition to outpatient care and diverting to outpatient care, there are some strategies such as using parking lot areas. So taking care of cases, COVID cases outside the hospital before they enter the hospital so that there's less risk for non-COVID patients. Using spaces that aren't necessarily often used, such as urgent care or daycare. that have appropriate air ventilation, use of discharge areas, and then changing patient flow placement, and of course the use of telephone or telemedicine so that people don't even come to the emergency room, and working how we can make that more efficient. This is an example from Durban, South Africa. And what you're seeing here on the screen is a layout of their emergency room. And in that particular emergency room, they were at the time, early in the pandemic, screening for COVID patients. And there was a patient who came and was placed in triage. Unfortunately, that particular patient was felt to be the focal point for a large outbreak in that facility. But what's interesting about this patient is a learning opportunity, which they provided in their 37-page, very detailed assessment of this outbreak, was that there was one emergency room physician who took care of this patient, saw a few other patients, and then came to see a second patient, which was from a nursing home. That nursing home patient then went on to infect 5 wards and also an outpatient dialysis unit, and then when they returned to the nursing home. So this was extensive spread, but the place that it started was the emergency room. And not to say that that particular physician was at fault. It could have been other places that there was a break. There could have been just the proximity of that patient to the triage area. But this, I think, is an informative place to start for lessons learned so that you can look to redesign your emergency rooms and figure out how to do it better. Some additional IPC consideration is respiratory hygiene, making sure that all patients have a mask. And as we know that cases are rising, we increasingly are concerned both for physicians and patients on the transmission. So again, this is using transmission and ventilated rooms. We've kind of went over this, but the important point I want to walk through is limiting healthcare workers. This is a study that was done in New York City, which tried to identify if there were cases of support companions of women in labor. So they screened the companions of women who are coming in to deliver. And what they found is that of the women who were asymptomatic, 20% of their support companions were positive. And among the COVID negative women, 9% were positive. So we expect that there are going to be visitors that are accompanying their family that have COVID and are potential carriers that can transmit within the healthcare facility. So in your emergency rooms, consideration of a visitor policy to limit the spread both to your staff as well as to other patients. You've discussed how to ration PPE use, using appropriate PPE use. One of the issues is taking advantage of negative pressure or natural airflow and using an appropriate respirator, an N95, if you're really in close proximity to any aerosolized generating procedures. One of those is intubation. And in an Israeli study where they simulated intubation and they used fluorescent dye, what they found is when that was going on, there were droplets that landed on exposed skin, on the neck, on the ear. And this is something that is of risk, especially to a lot of emergency room physicians who do intubations or involved in these, who need to wear appropriate PPE so they don't get droplets coming on themselves. And then also take appropriate precautions to take showers and decrease their risk, especially, of course, when they're going home to their families. The most likely place that healthcare providers will get COVID is self-contamination with when they take off their PPE. And this is when people are tired, when people have a lot of patients to see. This is something that often gets missed. And so simply putting up, as I'm sure many of you have, signage, and then if there's continues to be an issue, having spotters that monitor if they're taking it off appropriately, because you don't have an unlimited supply of healthcare workers. Environmental cleaning is another key area in the areas that are receiving COVID patients. Without environmental cleaning, we know from studies that were done in Nebraska and in Singapore that the environment becomes heavily contaminated with the virus. The good news is that this particular envelope virus is very easy to kill. On the spectrum of bacteria, spore, viral, fungi, it is a very weak and easily killed with disinfectant. So as long as you have a routine, as long as you're doing routine cleaning, at least twice a day is what's recommended. And there's a nice WHO reference for this on how to clean, how often to clean. It will take care of it, but it has to be done. And we also recommending cohorting your cleaning staff for COVID areas as well as your staff. High touch surfaces, of course, as pointed out in the red, are the areas where you really need to emphasize the cleaning, because they are the areas that are most likely to cause film-like transmission. Getting to screening of healthcare workers. So this is a large study that was done at a single institution where they proactively tested over 1,200 NHS staff in England. And many of the staff, despite testing positive, reported for duty. Many reported no symptoms. Some had mild symptoms, which they said, no, I'm not really that sick. It's not anything to worry about. And so many of your healthcare workers, because they're exposed, may have no symptoms or be taking their symptoms too lightly. This is another study that was done and tried to answer the question, and I put this in specifically because of your risk, is answering the question or attempting to answer the question, if you work in a red or a more COVID positive area, are you more likely to get it than a green? And so what they found is that they were 3 times more likely to get COVID. They didn't know if they got it from patients. From prior studies, we know that many providers, up to around 50%, actually got COVID from being in the community, not from the hospital. So just because your hospital staff test positive, based on the literature that I'm aware of, it's 50-50 if they got it from the community or if they get it from the healthcare facility. And again, this is one study, and so more work needs to be done. But to say that you're probably more at risk, although we do know that in the Durban, South Africa study, more healthcare workers were positive who worked in non-COVID areas than COVID areas. And that was felt to be because they felt that they had no risk for COVID or less risk for COVID. And so they didn't take appropriate precautions like hand hygiene and using PPE. And in this particular study, the key findings were that healthcare workers, the incidence is around 3 to 11%. And again, this 8% not having symptoms is concerning. It is therefore important to have some kind of screening program for your healthcare workers. And there are different ways that this could be done. And I'll present the different ways where it's possible based on resources that it could be done. The first is a passive strategy where you ask your healthcare workers to self-assess for fever or other symptoms of COVID. And again, we've now broadened those out to just include much beyond just the fever, cough, shortness of breath. Each individual institution may have their own criteria, and I know that CDC has theirs. So if the healthcare worker has these symptoms, they should not report to their facility. and report their condition. An enhanced strategy is you reminding them to do this once, twice, or more times a day. It can be automated by text, WhatsApp, phone calls, but there's some kind of enhanced strategy to make sure that they're doing the self-assessment. An active strategy would be that all healthcare workers are assessed prior to coming in for their shift. Or if they're monitored outside the hospital, they would not actually report to the hospital. They would report their symptoms, and if they were positive, they would not actually come to the facility as an active strategy. Some additional resource materials which may be of help. Of course, there's the NCDC and Ministry of Health. I will also particularly point you to the resource to operationalize triage, healthcare worker and inpatient screening, this fourth bullet point. This is a nice website that offers some operationalized guidance on how to do this. I want to acknowledge the Ministry of Health and Family Welfare for a lot of the work that they did early on in March, where we participated in their TOT workshops. Also to AIMS, which has been a great resource to develop these materials, and colleagues at the Centers for Disease Control. Thank you.
Over to Dr. Rajeev, and I think Dr. Kole, we can take the questions that are the last after Rajeev presents. Is that fine with you, sir?
Yes, yes.
Okay, thank you.
Thank you, Dr. Valan. And thank you, Dr. Kole and Dr. Dan for excellent presentation. So my topic is International and National Framework for COVID-19 Management. Because, you know, when we talk about the response, whether it is public health response or clinical management, when the government responds fast, the epidemic is not that serious, then the policymakers are blamed for overreacting. Whereas when they do adopt waiting strategy and advance too gradually, they are blamed for slow approach. Therefore, most of the governments of the world are resorting to legislation, especially dealing with the spread of such pandemic like what we are facing, and are incorporating measures such as lockdowns, curfews, and health emergencies, thereby banning international travel, movement of people at public places. Therefore, you know, we felt that need to understand the international and national legal and institutional framework for COVID-19 management and response, so that you know, to strengthen our system to fight this COVID-19. I have already given the rationale and introduction. Then we'll take international framework and national framework, and then we'll conclude. We all are, you know, living in a global village. A legal framework for any infectious diseases in the interest of public health security, and it is essential to increase transparency and accountability of every member state toward the public health preparedness and response. With effective human intervention, epidemics and pandemics typically end only when pathogens past has infected, you know, every available host, and all have either died or become immune to the disease. This is the two outcome. And the present pandemic have taught us that an outbreak like this in one country can easily and rapidly spread to another country. We are all responsible for stopping outbreak like this COVID-19 before they become epidemic or pandemic. And the international health regulations are a framework designed to better protect the world from health threats spreading out of control. This is why, you know, the international health regulation come in, and you might be knowing that how and when this has been declared as a public health emergency of international concern. This is a global aviation network. This is before pandemic. You see how many, you know, air traffic connections are from one country to other country, and within the country, within the region, and also global. Within 36 hours of time, one person can travel from one point of any part of the country to any part of the world. So within 36 hours of time, anyone can take a pathogen, or anyone can, if he is infected, he can take that infection to any part of the world. So how we are, so closely connected and living in a small global village at high risk. What is international health regulation? United Nations Health Agency. United Nations created WHO, World Health Organization, in 1948 with 165 member countries. This was the preamble of this was that responsibility for international health matters and public health preparedness and response. Beginning with the International Sanitary Convention in 1892 and continuing until today with the International Health Regulation, there were so many changes in the health response framework. And the recent one is the IHR 2005, which was paradigm shift from IHR 1969 to 2005. Before 2005, only 3 disease conditions were notifiable: plague, cholera, and yellow fever. If any other diseases, there was no provision to report. And revised 2005 IHR framework established a process for international collaboration and decision-making process during any public health emergency. And also it requires countries to report specific disease conditions plus potential public health emergencies regardless of its origin or source. It also establishes a global network of 24/7 national focal points. So every country has a national focal point, and that national focal point is connected 24/7. It also establishes core capacity for surveillance response for all member countries at all levels, from national, subnational, or local. It has 4 components, 4 thematic area: detect, assess, report, and respond. Detect, making sure that surveillance, every country should have a disease surveillance system and laboratory which can detect potential threat. How to assess, work together with other countries to make a decision in public health emergencies with assessment. And also reporting through the national focal point, report specific diseases or any potential international public health emergencies. And also responding to public health threat. So the mandate and the objective of this was that if any outbreak is happening anywhere, that outbreak has to be contained at the local level. If this pandemic could have been contained in Wuhan or in China, it would not have been expanded or disseminated to other part of the world. IHR 2005, it also includes specific measures countries can take at ports, airports, and ground crossing, so that it can limit the spread of health risks to the neighboring countries and prevent unwarranted travel and trade restriction. What is a potential public health emergency of international concern? PHEIC, we call PHEIC. Any public health emergency of international concern defined as a extraordinary event that may constitute a public health risk to other countries through international spread of disease and may require an international coordinated response. There are 4 criteria to define a PHEIC. If one criteria, starting with the first one, that is the public health impact of this event potentially serious, or this event is unusual or unexpected, or is there any potential for international spread, or is there the potential for travel and trade restriction? If any of 2 out of 4 criteria are met, countries are required to notify WHO within 24 hours of time. Still, there are 4 disease conditions. Disease conditions always need to be reported to WHO: severe acute respiratory syndrome, SARS, smallpox, new influenza viruses, any new strain, or wild type polio. DG, Director General of World Health Organization, determines if the event is public health emergency of international concern. So there is a process of international, identification of the international event, there is a screening committee under WHO that assess and evaluate the situation and recommend to the WHO DG whether that under their decision metrics it fits into PHEIC or not. And then WHO DG takes a decision. With this design, WHO as our global public health authority can quickly assess the global risk of any event or any outbreak, and if needed can convene countries to mount a coordinated international response. Like WHO now, you can see every week, like they have 2 to 3 times a week, they have a press briefing, developing all resources, publishing into their web portal. They have a very nice dashboard. And countries do not need to know what the cause or the source of outbreak is to report to the WHO. The focus is on early detection reporting to allow for a public health response so that before it becomes an international concern or before international spread occur. It, minimizes the global impact of the pandemic or outbreak. What is the potential public health emergency or international concern? Like this, giving this example, this is whether COVID-19 is an example of PHIC or not. Yes, because it fits into the definition criteria that 4 notifiable diseases, because this is SARS, so this fits into that criteria. We do not want to go into the 2 criteria out of 4 because this is SARS. Now coming back to the country legal framework. India has an excessively fragmented landscape for health policy. The Epidemic Disease Act is one of the elements of multiple intervention in public health in India. And the limited purpose of this law allows states to take extraordinary measures. And at the time of this dangerous epidemic disease, it does not establish any coordination mechanism between the state, the union government, or at the time of dangerous epidemic outbreak. Pursuant to COVID-19, we have been hearing about Epidemic Disease Act since a long time, and I will go back into the history of this. In Bombay plague of 1896, the Epidemic Act, how it was originated. It was originated after the infamous Bombay plague, placed in a similar situation like today. That time the administration had very little knowledge about that disease or the bacteria and its origin, but the disease was highly contagious like this, and much, contain the disease by reducing community transmission, or which could have been achieved by many other reasons or many other public health measures. And that has what that at that time the administration did, that they have restricted the movement of the people. Therefore, in order to restrict the mass movement and gathering of the people, because that time that outbreak causes a huge outcry among the people in Bombay, that masses from the Bombay, they fled from one place to other place, and there was a huge public congregation. How to control that congregation, how to stop that movement? Colonial era, during the British rule, they have decided to develop an act, and therefore that act was developed. And this act was adopted for better prevention of spread of dangerous epidemic diseases. And under the Indian Constitution, public health and sanitation are the responsibility of the state and local government, while the union government manages port quarantine, interstate migration, and quarantine. 8 states and union territory have a legislation for public health. The union government measures to prepare and respond to COVID-19 pandemic. What measures union government has taken so far? January, union government has invoked its power under Disaster Management Act 2005 to enhance the preparedness and containment of COVID-19 at hospital, notified the pandemic as a disaster, enable the state so that disasters funds can be used by the state response, In March, MOW advised state to invoke provision of Section 2 of the Epidemic Disease Act 1897. Also, as a signatory of the International Health Regulation, IHR, India needs to establish an appropriate public health response to international spread of diseases. With this, already, you are aware that Integrated Disease Surveillance Program, a nationwide program which is doing the surveillance, reporting, containment, isolation, disease investigation, contact tracing is under through this program. And the Epidemic Diseases Act 1897 and the Disaster Management Act 2005. What are those acts? I have already mentioned that this is a colonial law which has been now promulgated and revised, and it has various sections. Under section 2 of the legislation conferred discretionary power upon the state government to adopt temporary regulation. This is with the state government that they can apply their powers necessary to prevent the outbreak of such epidemic. And central government's power was inserted in by amendment in 1920. And section 2A gives powers to the central government, and section 3 gives the power to punish or offense if anyone if anyone is not following the rules. Epidemic Disease Act, why it was revised, why it was amended. This is the Government of India's major concern that pursuant to the zero tolerance approach of the central government, an ordinance was passed to amend the provision of Epidemic Disease Act 1897 with sole motive to protect the healthcare workers. Why I am putting this for the healthcare workers? Because all emergency management physicians or specialists, that if any violence against the healthcare workers from unruly behavior and boost to their morale in hours of crisis, this amendment criminalizes any violence against healthcare worker, where any person accused of such violence will face imprisonment up to 3 months to 5 years, beside a fine between 50,000 to 2 lakh. And in the case of grievous injury to healthcare workers, the accused will face a stricter punishment, imprisonment ranging from 6 months to 7 years. And they can also be penalized with fine ranging from 1 to 5 lakh. And this amendment entails a punishment of 3 months to 5 years, coupled with a fine ranging from 50,000 to 200,000 Indian currency for those individuals instigating violence against healthcare worker. So this is the major concern from the Government of India side to boost the morale of the frontline worker. Now coming back to the Disaster Management Act. However, in Epidemic Act has no institutional capacity building. In the Disaster Management Act, you have legal as well as institutional mechanism. Disaster Management Act 2005, it was before NDMA, all the disaster management was the Agriculture Ministry. Then this responsibility was transferred to Ministry of Home Affairs in June 2002. And with this act, NDMA established with an executive order in September 2005, and the Disaster Management Act passed in December 2005. Epidemic Act 1897, the amendment which is government has issued through an ordinance which will be required to pass in the parliament. So when the next parliament will come in, this ordinance will be ratified by the parliament so that it becomes a law. Disaster Management Act 2005, it develops acts, policies, and Disaster Management Act in 2005, Disaster Management Policy 2009, National Disaster Management Plan 2016, and National Disaster Management Plan 2019, which was recently released by Prime Minister, Honorable Prime Minister. Disaster Management Act 2005, a paradigm shift from response relief centric approach to proactive prevention, mitigation, preparedness driven approach. And I mentioned earlier also, it lays down institutional and coordination mechanism for effective disaster management at all levels, national and subnational. Under this institutional capacity development, that National Institute of Disaster Management was developed, National Disaster Response Force was developed, and under the whole framework, the Honorable Prime Minister is the ex officio chairperson of the NDMA, and it is created a multi-tiered institutional coordination system. And National Executive Committee chair is Home Secretary. This is a centralized or decentralized process, like State Disaster Management Authority headed by Chief Minister, Union territories are headed by Lieutenant Governor, and district disaster management authorities are headed by district magistrate and district collector. This has mandated that every state and district should prepare a disaster management plan, and also establish the setting up of the various funds so that if any disaster happen, you have resources in place. Also let down offenses and penalties. It's like saying that Epidemic Act, it has offenses and penalties as well. Empower the central government to issue directions to central ministries, departments, agencies, and also to states and union territories. State and union territories are also being advised or encouraged to use or set up state disaster response force and state disaster response funds. This is the institutional framework. You see NDMA, National Disaster Management Authority, chaired by Prime Minister, and National Crisis Management Committee, chaired by Cabinet Secretary, National Executive Committee, chaired by Home Secretary, and then it falls various ministries, those line ministries which has subject matter expertise. This is the legal and institutional framework. You see the central government, state, district, and panchayat, municipality, and also you have NDMA, SDMA, DDMA. So the best part is in that framework is that at the district level, chairperson of the Jila Parishad are also part of this framework. What are the other legal framework? There are other legal framework which support this pandemic, that Aircraft Public Health Rule 1954 that empowers health officer to check citizens arriving from abroad at airport entrance. And also the Code of Criminal Procedures, various Code of Criminal Procedures like Section 270, 188 or state specific acts and law. So many states and union territories have they have amended their own acts and law. I will also focus on the Drug and Cosmetic Act. This section 26B empowers the central government to regulate, restrict, or manufacture drugs in the public interest. You might have seen or aware that recently, government has banned export of hydroxychloroquine or chloroquine so that those resources should be in place for the country. Later on, they have lifted that ban, but this is the power with the union government. There are various state regulations like Madras Public Health Act. So various acts, I will not go into the detail of those acts. Thank you. It concludes my topic, and thanks to COVID-19 TOT workshop. And so I would like to thank Dr. Tamorish Kole, President, Asian Society for Emergency Medicines, for giving us this opportunity to be part of this webinar, and also our CDC. Thank you. Over to you.
Thank you, sir. The session is open for question answers now. The participants can please unmute themselves and ask questions.
I think there are participants who may be preparing for asking questions. In the meantime, I have a question to the CDC experts, and that is about community transmission. I know it is a hot topic, but what is scientific definition of community transmission, and how do we know community transmission has started? This is a question for doctors, nurses, general public. Everybody is asking about community transmission.
So, I mean, when you're talking about identifying cases, and I'm not going to get into what is definition or not definition. I think the principle is that if I can identify the linkage to that case, so that case is someone who I know where it came from, that is something that's not community transmission. Community transmission is when I have no idea where this person got COVID from, and I'm unable to put a specific link to where he potentially or she potentially got it. If I don't know and I can't answer that question, then I have to assume that it's circulating and there are people getting it from other people who don't know they have it, and I can't trace them anymore. Then I have to assume that more people could have it that I can't link. In the early stages, it was tourism, or if it was somebody traveling back from a city and I could link them, yes, they were the family member, or yes, they were a coworker, or yes, they rode in the car with them. Now, I don't know. They're showing up and it's unclear. You know, contact tracing has to be done for that to happen. And that's why contact tracing is a very effective way to know people's risks. If it's not being done, that doesn't mean that you have community transmission. It just means that you're not doing enough contact tracing to know. So in order to kind of truly define community transmission, you have to have a robust contact tracing so that when a case comes, that they can't tie it back to a particular individual. But if you're not doing contact tracing, then you won't know that either. So it's kind of a, you know, but the principle is that I don't know where the person got it. They don't know where, it wasn't clear to them where they got it. And if somebody did contact tracing, they would not be able to find out exactly where it came from.
Right, got it.
Thank you, Dan. Dr. Kole, I have a question for you. Thanks for sharing, you know, your preparedness and, you know, what regional or, you know, other countries or global, you know, emergency medicine department or emergency, you know, institution are doing. So my question is that, you know, in India, I'm talking about India, that almost 70% of the you know, healthcare, clinical care is with private institution and private. How, you know, private institutions are prepared or equipped if the cases, you know, does not stop, if the cases goes, you know, cases go up to the level that, you know, we cross over 1 million or 2 million cases, or we have more critical cases which needs to hospitalize or which needs clinical care. So are our private institutions are prepared to cater that, whether they have scaled up their capabilities for catering such, you know, cases if those cases came up in future or coming days?
So I think it's a good question. You know, you will recollect that in month of March, there was a projection done from one of the department from Johns Hopkins. And at that point of time, people were, you know, not happy with those numbers. They were very high. And we were believing that with lockdown, we'll be able to flatten the curve. Yes, we got the time for preparation. And we have done some amount of preparation, but it is appearing that that preparation is not going to be good enough. We need to do a massive search. Now, when we do that and when we plan to do that, the first and foremost principle in my mind is you have to raise away this boundary between public and private, because coronavirus does not know that. Patients will not present like that. They will go to the nearest healthcare facility, whether it is public or private, and seek help. Patients will obviously panic when they will deteriorate, and they will obviously try to go to the hospital where they're confident of having that facility, even if there is another facility which is lying vacant. And this happens in public health emergency in many parts of the world. India is not an exception. So the first and foremost in my mind is you have to erase this boundary between public and private and act as a one healthcare system. So that is point one. Point two is no single hospital is going to cope up with the numbers which are getting displayed as on today. So the second principle we have to adopt is what is also adopted in many parts of the world in public health emergency or pandemic is something called healthcare networking. So you pull up your staff, your resources, and run, say, 5 hospitals or 6 hospitals together. And in that, you put one hospital maybe for COVID operations, and the other hospitals, they can continue the non-COVID operation, and combination of that. Because somehow I feel this, this 15% or 20% or 25% reservation of bed in hospitals by law, what is, getting implemented, this may not be feasible for many hospitals which do not have adequate infrastructure, adequate bed structure, and adequate staff. We just learned how much staff is required, what is the precaution. So healthcare networking is going to be the second principle. The third principle is something very, very ingrained in disaster medicine and also in public health, which we did a webinar a month back, which is called crisis standard of care. You do not expect the normal, level of care which we do in a normal healthcare setup. If there is so much of surge, you need to use your resources accordingly. You need to change your policies accordingly. You need to divide your patients accordingly, and so on and so forth. And that is the principle of crisis standard of care. And that needs to come in practice. So if we do all these three, I guess we will somehow be able to prepare ourselves to handle the surge. Otherwise, if we continue to act alone and continue to have this divide, is going to be very, very difficult. The fourth and another important issue is that the cost of treatment, which is becoming a major issue in many parts of our country, that needs to be looked in. How do we do that? Can we standardize our protocol? Can we use our resources effectively? Can we look at subsidized treatment from government? Can the vulnerable population get some advantage during this time? All these things has to be looked into in total. So these are few thoughts in my mind. I hope the other panelists will be able to contribute in this direction.
Yeah, so
but it's a very, very important.
A follow-up question is, in the situation where you have consortiums of hospitals, or you have situations where you have designated COVID hospitals, but you also recognize that patients may be missed on a screening because they're pre-symptomatic or asymptomatic, is there hospitals that are performing screening of inpatients? I mean, we've talked about healthcare workers screening to identify, but also is there proactive identifications of patients who then turn positive? Because one of the lessons learned in this study that I talked about in Durban was that there was no system to screen those patients. And so by the time they were identified, there were many patients who were positive and also healthcare workers that were affected. And so in a system where you're allowing patients to go in and pick and choose, but there needs to also be some kind of proactive screening for those patients, or physicians who are aware that they should be testing. And so how is that being done in your facility or other facilities that you're aware of?
So I think Rajeev can answer this better, but I guess from time to time ICMR is changing the testing criteria. But there used to be a time where there was recommendation to test the hospital inpatients, the suspected ones who have COVID or who are vulnerable ones. I'm not sure whether the health system is able to do that currently, because there is also a push that all the patients should be taken care of and should not wait for test results, because as you know, the labs are getting overwhelmed. The test results are coming at the best 24 to 48 hours.
Yeah.
So the current principle as far as emergency care is concerned, that all patients who are suspected or whose emergency care cannot wait should have that care, and the healthcare staff will follow all sorts of precautions. But it is very important that to realize that the hospitals are hotspots and the patients should be tested.
I think you're very right. It's a very difficult question, and it has to do with access to testing, and then how do you kind of then funnel those patients to COVID hospitals once they're identified in a private facility or another facility. So not an easy question. I put that to you. I see there's a question in the chat regarding healthcare worker risk and instruments to measure. So I'm not aware of any particular instrument that can measure risk for a healthcare worker. You know, the risk comes into one, if you're in a COVID area, then you're exposed to more, but there's also some data to show that if in those areas, there tends to be a heightened awareness of the risk. And so there's a heightened use of PPE. And if that's continued and that's done properly, the risk is, you know, minimal because you're following appropriate precautions that protect you. And most of the healthcare workers that are following them, you know, protect themselves. In areas where there is a lack of COVID wards or COVID emphasis, those healthcare workers, at least in the study in South Africa, are even at higher risk because they're not following precautions. So again, it falls under the individual healthcare worker to one, always follow standard precautions, always protect themselves. And there's some facilities and some guidance coming that in areas that have high transmission, that all healthcare providers and all patients should be wearing masks inside the healthcare facility because we don't know who has it. As far as what the prevalence among healthcare workers, I've seen anywhere from 3% all the way up to 10, 11%. In the US, the studies that were done varied from 3 to 8%, and the 11%, the 3 to 11%, but the 11% were among the states where they were asking about their healthcare worker status, but it was felt to be a little bit of an underestimate. So no tool, but risk is more because you're engaging with patients, but you protect yourself by always following standard precautions and using PPE.
Yeah, Dan, like in addition to that, we can also recommend routine screening, like you mentioned, right? Like active and passive screening strategies, either self-assessment or something, or if there is an outbreak or something, some exposure, there are tools for assess the exposure risk of those individuals. So you can throw more light on that. And
yeah, sure.
You can show the tool also. Yeah.
Yeah, so we have something that we can send and you can disseminate. We can give it to Dr. Kole, and if you want, you can send it around as an example of how you can do screening. I don't know. I can try to pull that up while we have other questions.
Let me pull that up. Like you can continue. Just let me pull that up. Yeah.
Yeah. So, you know, for decreasing risk in the healthcare facilities, I think that the keys are limiting having appropriate triage, limiting visitors, having screening of your healthcare workers, and also screening of your patients. You know, and that patient screening can be either physicians just being very aware of symptoms and just reporting it as is. They could be screening the patients and then have some designated checkout where they're required each time they hand off to say, do you have any patients that have potential symptoms? And this could be done, you know, in the emergency room as well as a shift change. Or you can have an active screening where you have infection prevention control committee members, nurses, and or public health officials going into facilities and actively looking for cases in order to identify risk. So passive and active methods for investigation of healthcare workers as well as patients.
Sorry, I'm not sharing the right one. Sorry.
Yes, any more questions from the participants?
I have a question for Dr. Daniel.
Yes, sir.
Sorry, I joined late. But I want to know, is there any fixed guidelines for reuse of the N95 masks that are being given for the healthcare workers in a setting where there is relative scarcity of those protective gears? Any fixed guidelines that we should follow for reusing them? And what is the best way to save our health workers from co-infections and all those?
Yeah, so Valan has pulled up a PowerPoint, and these slides are available because we did these with AIMS as well. And so even after this, we can send you, or even put it in the chat box with a link for these slides. But Valan, do you want to go through this?
Yeah. Let me start. Yes. So you can, by the meantime, you can put the link in the chat box of AIMS. So when in the context of limited supplies, you can consider using reusable personal protective equipment where options exist, like cloth gowns, reusable goggles, or face shields. So this can be washed, and again, it can be reused. So also for reprocessing or appropriately followed, the right disinfectant is used, all those things has to be done. So, and also you should assign personnel as needed to, because you may be needing additional personnel for cleaning and doing all these things. And sometimes when you use the gown, it may have a hole or something, you have to have some personnel mending this hole and then using it, because otherwise there will be breach in covering and and you may end up getting infected because the PPE is not appropriately maintained. So now, can the N95 mask be reused after set period of time? So you all know very well that SARS-CoV virus can survive up to 72 hours on plastic, stainless steel, and cardboard. It may vary, but the thing is, if you see the mask of N95, it is made of some material of paper and cardboard plus some material with stainless steel where you have the nose piece and some plastic material. So if there are different strategies which can be followed for reusing this mask. So if it is not heavily contaminated and the fit test is there, if it passes the fit test, you can issue 5 N95 masks to each healthcare worker. The worker will wear 1 respirator each day and store it in a breathable paper bag at the end of every shift. And the next week, what he or she does is take out the first mask what she used for the day 1, and he or she can reuse it in the next week. So day 1, day 2, day 3, every day they can mark it and they can use. So this is a model which was used in US. So they will put it in a paper bag. They'll write the names of each of the staff, and it will be stored in a well ventilated place, and it will be reused after 5 days. Because as we know, after 5 days, the virus dies after 72 days, and viral particles have not been viable particles have not been isolated after 72 hours. So 5 days, they reuse it, provided the mask was not severely contaminated, or it is not there is no breach in fitting of the mask and all. So this is again, this is how they store. This is one of the strategy, but different hospitals adapt different strategies for storing this mask. So you have to be very clear when a healthcare worker should get a new N95 after getting these 5 pieces. So N95 after use during aerosol generating procedures should not be reused. if the respirator is contaminated with splash of blood or respiratory or nasal secretions or any other body fluids from patients, immediately you have to remove and use the next respirator because it decreases and there are chances of getting infected. And also following close contact with or exit from a care area of a patient co-infected with the infectious disease requiring contact precautions. That can be COVID or also like multi-drug resistant bugs like MRSA and things like that. And if it is again not fitted properly, you cannot use.
Yes, thank you, sir. I take this opportunity to thank the Asian Society for Emergency Medicine. And yeah, any more questions? Yeah, thank you to the Asian Society for Emergency Medicine and CDC office. Thank you to all the speakers for the excellent presentations and informative session. Thank you to the participants for patient listening. We'll conclude this session now. Thank you.
Dan, do you?
Thank you, Sweta and ITech. I guess Dr. Tamorish Kole is not online. So thank you, everyone. Thanks, Dan.
Thank you, sir.
Dan, I have a cough, that's why I stopped. Can you continue this N95 mask reuse?
Oh, sorry, sir.
Sorry.
Can you project? So the N95s, like Valan was saying, is that there's times where you can rotate. And I think that's the most common thing in India that seems to be the most feasible, where you give 5, that I know that AIMS is doing this and they have a video on how they do this posted on their website the rationale is because the COVID virus can't live on plastic, steel, or cardboard or the paper for more than the 72 hours. And so that's why you're kind of able to kind of just leave them lie, let the virus die, and then go back and reuse it. Then it becomes an issue of, do I need another one because it's wet, it's dirty, it doesn't fit to my face, or another reason that's fairly often? Or did you use it during a aerosolized generating procedure and it's considered highly contaminated and you really should use it so that you don't run the risk of touching it and then touching your face? There are other methods of decontaminating the mask that have been postulated. And so decontaminating the mask has things that, and all of this has very limited evidence. So you have to say this is very limited evidence. And so we'll go through these, okay? So next slide. So there are sites that are using UV light. There's a protocol out in Nebraska. We can skip over some of these because we gave them the references for these. So let's go to the UV. There's a protocol out in Nebraska that says you can use UV light. The problem with UV light is that there's no standard. So I can't tell you, you have to kind of look up, and actually on the references to this, in this PowerPoint, there's a NIOSH website that does give the protocol. So if you use UV light and you want to know the protocol on the CDC NIOSH website, it'll give the protocol. But just know that you have to follow the protocol with the exact UV and keep it, and don't allow your healthcare workers to be exposed in a way that adversely affects their health. It also is limited in the number. I think that UV is 3 times and then you have to discard. So it's not, you can keep using this forever. So, next slide.
This is the protocol for
So this is the protocol page. And so here at the bottom, and again, these slides are in the chat box, you just click on it, is the place where you'll find how to do each of these. So steam generation or moist heat, you know, the virus doesn't live above 60, 65. And so if you hit it with heat for 30 minutes, it'll die. But what does it do to the mask? That's where the kind of questions come into play, and how often can you do that? Next. I think we have 2 slides on protocol. Yeah, this is just another protocol for the vaporous hydrogen peroxide. So that's another way. And then these also go into what's the mask quality. So unless you've kind of skipped over some slides. Well, or you can go back, but some things like chlorine, you don't want to use. It's not effective. Ethylene oxide is toxic to the wearer. It causes neurological issues. It also causes teratogenesis. So that was kind of early on, but definitely it's a hard no on ethylene oxide. And you know, wiping it down with alcohol. These N95s have a charge, so they're layered and have a static charge. And part of their ability to filter out particles is that charge. So anytime you're messing with the charge by using chlorine or using alcohol or using it, it gets wet, it damages the mask, and so it no longer has that filtration efficacy. So the best case scenario is you have enough N95s. I think that the most practical application is that you rotate. And then if you don't have that, then you look at one of these methods that you have access to and can follow some kind of standardized protocol in order to do it as an institution. But you really should assign somebody to do it. You don't want to just do it yourself. If you're going to do it as an institution, you want to have dedicated staff. That's all they do.
And if you visit this website, like it has like all details about like what is allowed, what is not allowed, and how long you can use, like, and what type of mask. Like for different companies, they have different specifications. So what kind of mask can be like reused? Which has been already established scientific research and things like. So all these things are available. So already Dan has shared the slides. You can click on the link here and you can get all the information from CDC website.
So another question that came up in the chat box was around N95 in the paper bag. So the paper bag is used because it tends to withdraw moisture from the N95, but it has to be left open to the air so the air circulates in and out of the bag. But the whole purpose of the brown paper bag is because it helps withdraw the moisture, not because it has magic to it. But it needs to have that open circulation. And on these face masks, they can also be reused, and they're difficult to clean because the viruses and bacteria can get into the foam. And so for it to die, you have to just let it sit until the virus dies. Then you can reuse it again. But it's the same principle, but it's the foam that's an issue. You can wipe down the outside with alcohol or chlorine. Sometimes it can discolor it or make it go white, but that's a way to clean the plastic. It's the other pieces that make it harder to clean.
The head pieces.
So hope this answered your question.
Yeah.
Thank you.
Thank you.
Thank you.
Any other
Can we take one more
questions?
question? Can we take one more question, sir?
Sure.
Yeah. I want to ask about ED manpower. For ED personnel, other than comorbid status, who should you avoid works on the ED during this pandemic period? Are there any guidelines for pregnant personnel?
Yeah, so of course, anyone that has a high risk, if they got coronavirus, of death, which would be comorbidities and over 60, 65. Those individuals, you know, has to, and sometimes it's a personal decision, sometimes it's a policy decision. We've seen hospitals that have policies where they try to take those staff and they assign them to areas where they have lower risk, or to do telemedicine instead of the emergency room. Because if they do get it, then if they die, then they're dead, you know, they can't give any health care. But there's also the limited personnel to rotate through. For pregnant personnel, and this is where I may need to kind of reference this and get back to you, but I think that if they're pregnant, they should not be working. Because there's a lot of uncertainty, you know, for pregnant women. You know, we've seen some studies where the breast milk can transmit it to infants, but there's some studies that say it doesn't. So there's some inconclusive. As far as their morbidity, mortality, like with COVID, I haven't seen any studies that have the power to say what the outcomes are, but why take the chance? So I think that the evidence is still evolving for pregnancy and exposure in pregnancy. And if it results in the fetus getting COVID or having adverse outcomes, Valan just posted a link.
Royal College of Obstetrics and Surgeons.
Yeah.
So RCOG, they don't recommend pregnant workers because still the same thing what you told. Vertical transmission is there or not, it's not yet established. And like still the virus is under study, so it is not recommended.
And there are some specific, you know, Pediatric Society has guidelines, Surgery Society has guidelines, that precautions to take. And so, you know, each individual group is starting to come out with their experience and collect information. So often going to the society websites, you'll find guidelines. I mean, some of which we have, and some of which, you know, all this evidence is just coming out so fast. And it's changing, so we have to keep ourselves updated.
Yes, I think we can conclude this session.
Yes, sorry.
Thank you to all the no problem, sir. Thank you to all the expert speakers and participants for their valuable time. Thank you, sir.
Okay.
Thank you. Thank you all. Bye.